This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello friends, this is an elderly male patient who is one-eyed. The blind eye is PL negative and he has a complicated cataract with band keratopathy, and the good eye is complicated as well. He has intermittent cataract, pseudoexfoliation and a non-dilating pupil. Additionally, the cornea is not great. It's slightly hazy because of mild spheroidal degeneration. The patient is hard of hearing as well. So looking at these complexities, I have consciously decided to use a peribulbar block for the patient and then proceed with the surgery. The main issue here would be to deal with the pupil. So if we can visualize well, the further steps of the surgeries would be quite routine. Now this is a rigid pupil and I would want a slightly wider pupillary dilatation in this patient, and here I'm going to use a Gupta pupil expansion device. A few factors to consider here while introducing the expansion device. Number one, the chamber is going to be shallow and the lens also is swollen. So there's not space between the lens and the iris. So during the manipulation of the device, there is always a risk of damaging the corneal endothelium anteriorly. At the same time, there's also a remote possibility of touching the anticapsule and opening it up. So I need to be mindful of these things. So let's begin. The two side ports are created. The anticapsule is stained with trypan blue. Under the air bubble, dispersive OVD is placed into the bag. The globe is stabilized by a second instrument, and I am creating a triplanar limbal based incision. Now, before putting in the Gupta ring, I would like to reinflate the chamber with OVD, and for loading and implanting the Gupta ring, we typically use the butterfly cartridges which we have with our hydrophilic lenses. The distal notch engages the pupillary margin, but the two side scrolls are unable to engage, but it's alright. So many times when we struggle to engage the side scrolls in the first attempt itself, during this manipulation there is always a risk of touching the anticapsule and opening it up. So it's perfectly okay if the side scrolls are not engaged in the first attempt, and then using a Sinskuk, each of the scrolls is then retracted and then engaged onto the pupillary margin. Engaging the last scroll is going to be a little bit tricky because we really need to pull the device a lot, and eventually it gets engaged, and now we have got very wide pupillary expansion. So only the central part of the pupil is stained well, so I want to restain the peripheral part of the capsule, although the restaining will not be as effective as the primary staining, simply because the capsule would now have been in contact with OVD, and that would prevent the capsule from taking up the dye very effectively. Nevertheless, something is better than nothing. So in these white cataracts, I think visualization really helps us to make the surgery safer. So it's worth the attempt. So in this case, I'm going to use the forceps to perform the rhexis. The anticapsule is punctured, the flap is raised, and I'm going to perform the rhexis. So now we have an adequately sized rhexis. So now is the time to manage the nucleus. Now with such good visualization, the surgery actually becomes very simple and a routine one. So the nucleus is not very dense. So I'm going to perform a direct vertical chop in this patient. The tip buries into the substance of the nucleus, and then the chopper is going down vertically and then laterally. So the nucleus now broken down into multiple smaller fragments and then emulsified in a very controlled manner. So these cases might look very intimidating to begin with, but the secret in such cases would be to break down all the steps of the surgeries, identify which are the ones which are very critical, and then if we address those issues in the beginning and plan appropriately, you'll be surprised that most of these cases, the surgery would be uneventful and perfectly routine. So again, as I keep saying, planning is the key. Time to remove the cortex. In these mature cataracts, you don't have the sheets of cortex wherein which we can nicely peel off. But instead, we have these isolated fibers, and which can be challenging and tricky. So you need to be a little bit of patient to identify each of these fibers and then remove it. Time to implant the lens. The bag is inflated with OVD and the planned single piece hydrophobic lens is gently maneuvered into the capsular bag. Now time to remove the pupil expansion device. Now this is a biplanar device, so removing it is a little bit tricky compared to our BHEX device, which is extremely simple and fast. First, the scrolls are disengaged from the pupillary margin. It's important that we are very sure that all the scrolls are disengaged from the pupillary margin and they're above the surface of the iris. Now when you're trying to pull it out, I'm going to use a flat spatula that's like a iris repositor. Press it down against the floor of the incision so that the scrolls don't engage the floor of the incision and then they can be easily pulled out. Now this is a small trick which really helps to remove this pupil expansion device quickly and safely. Time to remove the OVD both in front and behind the lens. The ports are hydrated, that's it, the case is done. So to summarize, some cases might be looking intimidating to begin with, but if you can plan them well, most of these cases can be sorted out quite easily. In this case, the issue was visualization. The issue of visualization was sorted out and the case essentially became a routine one. Thank you for watching and hope you found this helpful.